everyone.
Hi, everyone. Welcome to Lina and Radha's show.
Welcome to another
well.
episode. Yes, another recorded one, as you guys can see. And this one is going to be probably one short episode.
Yeah.
But we wanted to discuss with you guys two new topics that we are seeing in the new TG compared to the old one.
So hope you are doing well. The last sessions were beneficial. Today we are going to talk about Peri-Implantitis or peri-implant disease, more precisely. Page 76 in new TG. It's a very new chapter, paragraph in new TG as compared to old TG.
Yes, I think they are acknowledging how common implants are nowadays.
Yeah.
So on daily basis, we tend to see a lot of patients that are already having placed implants. So I think it's quite important for the general practitioner to understand that an implant can go through also some form of periodontal disease. So here we have new terms. Well, they are not new because I think we all know these terms, but they are new regarding TG because these ones weren't included in the old TG.
Exactly. So they first begin by proposing you the definition, what is a peri-implant mucositis and what is a peri-implantitis, which is quite different. Peri-implant mucositis is just a reversible inflammation of the soft tissue around the implant, whereas peri-implantitis is when it involves also bone loss, like an inflammation of the whole periodont, and that can lead to a loss of the implant because it's irreversible.
Correct. So basically, it's like an analogy for gingivitis and periodontitis. So perimucositis will be the equivalent to
gingivitis.
Yes. So basically, the management for peri-implant mucositis is non-surgical debridement, advice on oral hygiene, and obviously encourage the patient to get, all the regular visits just to maintain those implants. And same as in a case of gingivitis, no antibiotic therapy is required for this. So basically, taking into account that this is a reversible stage, basically what we need to take in mind that prevention is going to be the key in order to try to prevent or reverse peri-implant mucositis.
And then they talk about the management of peri-implantitis, which includes the same as mucositis. So you have the debridement, which is non-surgical. You have all the oral hygiene instruction and improvement, and if the patient is smoking cessation, following up and maintenance, plus you would refer to the specialist, which is normally a periodontist, but could be an oral surgeon as well, because we might need a surgical intervention. So bone graft, soft tissue graft, and here the thing is that we might require, or we are most likely to require, an antibiotic therapy.
Correct.
So here they are telling you that you need to prescribe. I mean, you, I think it will be the specialist, but the amoxicillin and metronidazole.
Yes, and again, if we're trying to do the exercise on how to extrapolate this to an OSCE situation, obviously, if soft tissue grafting or surface decontamination, hard tissue augmentation is not something that the general dentist is going to do, you need to be informed of those possibilities to inform the patient during a possible consultation, or information gathering scenario, something like that. So I think it's quite straightforward, and we need to be very well trained on how to communicate these things to the patient, how to explain the difference between a perimucositis to a peri-implantitis, same way that we will explain gingivitis or periodontitis. And I think that's pretty much it for Peri-Implantitis and Peri-Implant Mucositis, because I do remember that there's a case in the OSCE scenarios that talks about a patient that comes with a bridge, which is implant supported. And apparently the patient is having some kind of presentation similar to mucositis or peri-implantitis. So if you guys know that there's already a case out there that is part of the OSCE scenarios, you would like to try to take this information and try to rehearse that possible OSCE with this new information that you have here. And we have said to you guys in many, many other occasions that you like to vary, you know, the approach for every single OSCE. So you can rehearse that particular case as a peri-mucositis, and then you can switch it around and spin it around and rehearse as a peri-implant and peri-implantitis, just to for you to own, you know, your own speech and how you are going to explain this particular presentation to the patient.
And also maybe you could talk about one scenario that would talk about the management, another about how the questions, the information gathering, and how you're going to conduct the examination, like probing, x-ray to see if there is bone loss, and so on. So try not to just focus on the management, but also information gathering and the investigations.
Yeah, quite important in here. Again, it's just about an integration of all the information that you already have and establish which things are suitable for any particular case. And remember, it doesn't matter at how many or how point in time you are watching this episode. If you are watching the live streaming of the episode, just leave your questions on the comment box, and if possible, we will try to gather all of those questions, either if we do it, you know, in another separate occasion, or if we are going to do a Q&A live session, we will be happy to take all your questions and try to discuss possible variations to these cases.
Yeah. So now we're going to jump at the end of the, quite the end of the new TG with the complications after oral surgery, page 221. So first they're talking, which is a new chapter. So it's about pain first, pain and swelling after oral surgery. So what are they telling us, Lina?
Well, basically, I find this chapter quite good because it's like a roadmap for you to know what to communicate to those cases that involve extraction for patients in OSCEs. Because we know that pain and swelling is not only related to infection, and they have taken into account that in this chapter. They're telling you if you have a complex extraction of wisdom teeth, probably the patient is going to experiment some bruising or swelling or pain even. So because we just remove a tooth. So in this particular case, they're telling you here, what do you need to do with those patients? Like if the patient comes after a complicated extraction and tells you, I have a lot of inflammation or swelling and also a lot of pain, it's not only related to infection, because we already know that the incidence of infection associated to an oral surgery is quite low, even if we are talking about complicated wisdom teeth. So here, basically, they tell you the management. This is pretty much what you need to say to the patient. It cannot get easier than this, guys. It's about reassurance to the patient. Tell the patient that it is completely normal. You can explain to the patient if the surgery was quite complex, removal of bone, raising of flaps, stuff like that. So you need to apply some local measures, cold compress for 20 minutes at a time during the first 24 hours. Obviously, NSAIDs, if the patient can take those. Communication with the practitioner who performed the oral surgery, if someone else did it. If you did it, you can manage the patient even better. And obviously, monitoring the patient's condition. So in this first part of the chapter, you will think, oh, this is quite straightforward. Yes, but a lot of people miss that management of postoperatory pain and swelling, because it's not always related to an infection. A patient can come swollen, and it's not because the patient is developing an infection. So we need to be able to manage that.
Yeah, that's pretty much about that.
Yep.
Then they talked about dry socket, which is basically the same as the old TG. Then they are talking about bleeding after oral surgery, and they are giving much more details actually, and they are summarizing everything on table 23 about how you are going to manage the bleeding after an oral surgery. So from the initial screen and management that you can be done by phone when the patient is calling. Okay, I had this extraction or surgery or whatever, it's bleeding, what I can do. Then you just reassurance and that when you see the patient, how it's very detailed, sit the patient upright, place a gauze or a clean cloth directly and form it over the surgical wound. So that's before he comes. Apply pressure and what to avoid. So if it doesn't resolve the problem, then what will be your initial management? So the patient should come, what you will do locally, and then if what you can do if you couldn't perform any management or you were unsuccessful. So you would arrange a transfer to the emergency department.
Yes, and basically, again, they are telling you this because bleeding is not only going to be related to antithrombotic therapy.
Yeah.
So, because the first thing that you think when a patient is bleeding is that the patient is taking some medication. What if it's not related to that? And this particular table that Rada just explained, it's about how to manage those patients that are bleeding more than normally, or even if the bleeding is severe, then you go all the way down to the table and try to manage it. But again, remember, not every swelling or pain is related to infection, and not every bleeding is related to antithrombotic therapy.
So even here, they say, for instance, a patient who had multiple teeth extracted. So it could be likely the cause, but if we have multiple extraction sites, in the opposite of the previous case, maybe it can raise awareness about a systemic condition that we are not aware of, or the patient is not aware of. So here maybe we can refer to the hospital if we cannot manage the bleeding, or management plus referral to the GP to see if there is any underlying condition.
Yes, definitely. I think those two particular chapters or information is quite valuable, quite telling regarding OSCEs, because if I was still a candidate from ADC and I will see this new TG, I will take a look to every single new thing in there as a possible future OSCE.
Yeah,
and
exactly.
That's pretty much how you need to think about all of these changes and try to implement any kind of rehearsing just to tackle these things, because some things are quite easy to read, and when you read it, it's quite straightforward, but communicating that to a patient in a time frame of 10 minutes, that's a different challenge. And that's why you guys need to interiorize this, digest this information in order to be able to communicate that effectively.
And also, I'm not telling 100% that they are going to do that, but since they have one full year, they might change the whole scenarios. We don't know. I don't want to scare anyone, but we need to consider that. We need to take that into account because we have new TG, we have 1 year. These guys, they didn't work basically. So everything is possible. So just don't rely on the previous cases and try to figure out any possible case and try to work with your study partner.
Make them best and the most out of the time that you have on your hands. We also have spoken about this before, about trying to, And this thing doesn't only apply for you guys, because as dentists nowadays, Brad and I, we have to face, as well, reduce hours from our work, because it's the same situation for everyone here. So every situation from a different perspective, yes, but you need to make the most out of the time that you have in your hands and try to concentrate on a study a lot.
Yeah. All right. That's it.
That was good. Don't forget to leave the questions, guys. Put it there. We are having a really, really good time, try to establish all these new versus old TG things. And I think it's going to be helpful. And the more information is out there, the better it is for you guys. So that's the whole idea.
So we see you next show. And we wish you hard work and good luck. Bye-bye.
Yes. Bye.